So a few housekeeping items. You won't need your video or your audio on during the webinar. So you can go ahead and turn both of those off if they aren't already. If you have any technical difficulties, you can contact the Chicago Asthma Consortium in the chat. Either myself, Rochelle, or the association account. If you want to chat during the presentation, we encourage that. Introduce yourself, say hello. If you want to talk a little bit about where you're coming from and how you sort of relate to asthma or how you typically interface with it, feel free to put all of that stuff in the chat. If you have questions for the presenter, you can also put that in the chat. And as we get to sort of the end of the conversation, then I'll aggregate all of the questions that have come in while Marc is presenting. And then during the question and answer session, I'll make sure to ask all of your questions, and we'll make sure we get answers from Marc. And then at the very end of the webinar, you'll also see a link go out for an evaluation. We really appreciate if you would take the survey and let us know other topics that you might be interested in, other ways that we can improve the experience of these webinars. We do take it very seriously, and we do read all of the responses. So please do follow that link at the end of our talk today. And a little bit about the Chicago Asthma Consortium. Our mission is rather simple. We are trying to improve the quality of life for people with asthma. We do that through advocacy, education, and collaboration. So basically convening folks from across the city of Chicago who either have asthma or interface with asthma issues or just passionate about making sure that people with asthma have a good quality of life. And then we all come together to talk about the things that we can do as a city to improve our air quality, improve conditions for people who have this disease. And that includes public health professionals, business leaders, government agencies, community-based organizations, and just individuals like myself who have asthma and care about this. You can help us make an impact by either going to our website to learn more about upcoming events. We have a conference in May that's coming up. We'd love to see you in person. You can also become a member of the Chicago Asthma Consortium. And on our website, it'll tell you a little bit more about that. And the Chicago Asthma Consortium is a completely volunteer organization. We've been around for 30 years now. And our structure is that we have certain committees that, or work groups that are on various topics. So we have a community advisory board that informs research. We have a community engagement group that is bringing educational resources out into the community to just make sure people are aware of different things about asthma as a disease. We have a fundraising committee. We have a membership committee. And then we have the professional development committee that puts on topics or forums like what we have today. So we also are accepting board applications. So if you're interested in joining the board, you can chat to me. You can also send an email to info@chicagoasthma.org, and we can tell you more about that process and how it works. And with that, my portion of this is over. So you don't have to listen to me talk as much anymore. And I'll pass it over to Marc in just a second, but I just want to give a little bit of a bio for Marc, who has been a great friend of ours for a long time. So Marc Rubin is a BSc Pharm and a retired pharmacist who works in both hospital and retail pharmacies for years. Marc is a certified asthma educator and has provided many trainings addressing environmental control as well as medication therapies for people with asthma. He's past president of the Suburban Asthma Consortium and has been a member of the Chicago Asthma Consortium for many years. As a coach and director of safety for the Crystal Lake Soccer Federation, Marc mandated all coaches be trained in understanding asthma and how to respond properly should the need arise. and to maintain a safe environment for players. Currently, Marc is also with the Asthma and Allergy in Older Adults Committee of the Quad AI, which has developed an exercise prescription for physicians to utilize for improving quality of life in the elderly population for medical issues. So thank you, Marc, for being with us today and for presenting on this topic. And I'll pass it over to you to get us started.
Thank you very much. Appreciate the compliments. I'm also on the sports committee of Quad AI. It covers one of the things is exercise-induced bronchospasm, and the PowerPoint that I worked on is approved now at the Quad AI site. So if you're interested in how to work with exercise-induced bronchospasm, if you go to quadai.org, then you can go, well, you have to contact me because apparently they want where the professionals are presenting to organizations. But thank you very much. So on today's presentation, we're going to discuss the evaluation of proper technique and which devices should be chosen. And a lot of this depends on the peak inspiratory flow testing. And teach back technique is more than just visual, as you're going to learn. There's more to it. So we can go on to the next slide. Okay. Really critical points for inhalation of drugs. We have to evaluate the patients and the importance of education and training inhaler device. You can't overemphasize it. And just curiously, yesterday, I was at a bank and having a meeting with one of the people there who has asthma her whole life, as well as her child. And after I was discussing things back and forth, she had her rescue inhaler with her, and I had her demonstrate how she used it because she's also on a combo inhaler too. Her technique was not correct. And studies have shown almost 80% or so of healthcare providers do not know how to properly execute with the various devices, which means the teacher flunks, which then leads to a lack of execution with the patients and their decreased potential for quality of life. The choice of inhaler is to be individually tailored, depends on a number of factors, the ability to get it, and a lot of that could be insurance determination of what they're willing to cover, the cost of the patient, the prescriber and what their familiarity is, and most importantly, the patient's ability to accurately use it and their preference, because it's shared decision making. Because some patients might feel that they're uncomfortable with a device, so you've got to listen to them and get something they feel comfortable with. It's essential to provide instructions and demonstrating the technique when prescribing the device. And there's a number of things that are important. We'll cover a little bit later on the three aspects to make sure they're getting the instruction properly. And then the inhaler technique, according to the guidelines, should be assessed before concluding the current therapy is efficient. And technically, if a patient is going to the physician every time, they should be assessed before they even see the physician to ensure that if they're not doing well, is it technique or are there other mitigating factors bringing this on? Next. Okay. The in-check dial, which I also have here, is a device. I'm going to make sure it's facing the right way for you guys. Is a device, it's like a reverse peak flow meter that, unlike in a peak flow, where you're going to set it to 0 and blow as hard as you can to see what zone you're in when you've properly measured what your ideal is, this is the reverse. This is the strength of inspiratory flow, predominantly used for dry powder inhalers. I've been teaching about this for 7, 8 years now, and what really got me involved was at a presentation of Quad AI that I was instructing about this. And at the end, a doctor who's a major researcher, pulmonologist, who's now at Mount Sinai in New York, came up thanking me, stating that 80% of pulmonologists are not doing this, which is why the amount of recidivism or failure of therapy is occurring because the patients are not getting the medication into their lungs. And if you're not doing it properly, you might get minimal, maybe none at all. But as you can see on the chart, you've got the range. The ideal range is 30 to 90, but you're really trying to do on an original evaluation that they're getting to about 60 liters per minute. We can go on to the next slide. The device, unlike a peak flow meter, has various resistance settings. And on the side of it, which I'll show you here, hopefully that's coming out where you can see it, actually lists the different devices and what setting to use. So when you get the setting aligned, which is done at the end of it with the pointer, then you're going to go through the procedure of evaluating their inspiratory flow, how strong it is. Predominantly, what you're going to do this is, like I said, the dry powder inhalers. Next. So as you can see, they've got little icons on it also when you've got the paper chart showing the types of things. So it's not always just the written word on it, but it's showing the different products that are covered by it. Next. Okay. Because it can be used for multiple patients in the doctor's practice or in a hospital, they come with boxes of like 200 of the disposable mouthpieces, which is inexpensive. The device itself is only about $125. The mouthpieces are super cheap for a practice to have, and they do have a filtered one that can help prevent cross-contamination. Another thing that a company that distributes this nationwide has a sterilizer unit that's inexpensive. You can have like a half a dozen of these sitting in there, and in 5 minutes, the device is sterilized for each use. Moving on. There is CPT coding for the testing. So it's not like a practice is going to be doing the testing with no reimbursement. You actually can bill for it, and the reimbursement range for this 3-second test is in the mid $30 range. It can only be billed if you're not doing another pulmonary function on the same day where you're already billing for that. So there is reimbursement. It's not a freebie. So that way it's not a loss of time for the doctor not getting reimbursed. Doesn't matter if it's a doctor, the nurse, or respiratory therapist, moot point. Moving on. Okay. The basic steps for inhalation delivery device determination. This is critical. This is also, if you're familiar with the GOLD guidelines, which is the Global Obstructive Lung Disease Guidelines. It's an international organization, and they state specifically cognitive skills first. They have to understand what you're speaking of. They've got to be able to have good communication. And needless to say, multilingual societies, that can sometimes be a bit more difficult. Manual dexterity, when you're dealing with a child, they may require that spacer chamber because they might not be able to effectively activate the device. Or with older people, arthritis, hand injuries, they've got to be able to show that they can use this without repeated verification. Then comes the PIF test, and that's peak inspiratory flow test for the dry powder inhalers. And this should be done initially. This would be done by the physician determining they need an inhaler delivery system for the disease, the disorder. But once that is the determination and going through the different phases, the shared decision making, is the patient comfortable with the device? And if they use something else, again, you're going to be evaluating them for the different dry powder devices because many of them have multiple drugs, just like an original one that an insurance company might cover. Insurance might say, we cover this, and the patient fails a PIF test, but there's another one that might be easier to use. You now have objective data to go for prior authorization, explaining the fact they were not achieving the required efficacy on the device. Then if the patient has more than one inhaler, try to have them all using the same delivery method so there's consistent training. And the bottom, of course, is the wonderful insurance coverage. I also dealt with the woman yesterday on that she was originally on, I believe, Dulera, and the insurance company would not cover Dulera. A lot of fun that they don't think about the patient. It's all about their money. Next. Okay, so how to use it. Basically, real simple and straightforward. You'd be checking to make sure that everything is clean. you have a fresh device, and it actually has an arrow, let me get this here, showing which way the airflow should be. Then you insert into the mouthpiece, and you tap it down. There's a weight at the bottom that resets. There we go. That resets here. Okay. And once you've done that, I'm going to align this with, oh, let's say a medium resistance unit. Okay. Now, critical is you want to exhale slowly and deeply. That is the failure with almost every single inhalation product, that people are not exhaling, let alone deeply enough. So exhaling deeply, then you seal the lips around the mouthpiece. And depending on the inhaler chosen, you're having the patient inhale what the manufacturer recommends in that manner. Then you're recording the inspiratory flow with the red cursor against the scale, and I'll show you when I do it. You reset and repeat 2 more times. And if you're familiar with spirometry evaluations, spirometry must be done at least 3 repeats to get 2 of the numbers very close together for accuracy and duplication. And then you're going to compare the values for the target flows of the device, wanting to be in optimal range. Okay, so tap down. And on this resistance, I actually would have had to inhale slower because it went all the way to the top. So I'd have to have a device that might have more resistance. Tap it down. And then with this setting, I am now at an ideal range. And you can see where that red marker is in here. Trying to see if I get the camera right, because I can't see it on my own. Oh, there we go. There it is. So you can see that I am in that green zone. Okay. And that would be the determination of the proper setting for it. And that setting I actually had was the yellow one. So that would be for like a turbohaler, the Symbicort, for instance, Spiromax, or the Gen Air Press Air. So that would be fine for that. Okay. And if you're having multiple inhalers, then it'd be evaluating for that also. Next, please. Okay. So the speed of inhalation, it affects multiple things. So because going through it'll affect the delivery of the device, a change in speed to a particular inhaler can affect the aerosol quality, how much is actually, not quantity, I was right in the first place, the actual amount that's getting into the lungs, which is really critical to get the full dose. The quality is determined by the average particle size, ideally from about 1.5 to 5 microns. So that's going to affect the inhalation power also. Consistency, wanting that the dose admitted over the entire duration of puffs on the inhaler are consistent. How much lung deposition is taking place for the total dose delivered that's getting into the lungs. And you're wanting to reduce side effects, because if you're not having adequate inspiratory flow, more of it is ending up in your mouth and your throat, in the pharynx, where you're not really relieving the situation in the lungs, but you're more likely to have side effects like getting thrush. So variations in clinical effect really is determined by the strength of the inspiratory flow. And sadly, when the physicians are not doing this test initially, let's say the patient's not improving without doing the test, they might feel that, oh, we've got to go to a higher dose. So they're prescribing a higher dose in the same medication, or they're adding another medication when they failed on the very first step of determining, is this the right delivery system? My standing joke is, when you have a wedding, do you have the food delivered by motorcycle? And if you order a pizza, does it come by semi-truck? No. It is critical that the correct delivery system is chosen that's appropriate for the situation. Next. So as you know, there's many different types of inhaler devices. The dry powder inhalers, the meter dose inhalers, the soft mist inhalers. Then you've got developed holding chambers that can be used with the MDIs and nebulizers. One thing that's consistent with the MDIs, they all function the same. The issue that's so critical of the dry powder inhalers, we're seeing more and more, is because of movement away from meter dose because of the effect on our atmosphere, they're using more dry powder inhalers, but there is no standard design that's consistent from product to product as far as that resistance on inhalation, which is why this PIF test becomes so critical. Moving forward. Okay. So when you're dealing with the more severe pulmonary patients with obstruction of the lungs, like I was saying before, it's critical to assess this flow before determining just writing prescription for it. You need to evaluate to reduce the risk of failure just due to the inspiration weakness of the patient. And getting this training to maintain proper inspiration, it's like when the patient comes in, when you've got COPD, it's a chronically debilitating decrease in quality of breath. You can't assume that they might be on the same device for a number of years. It should be evaluated each time the patient comes in. There's a doctor out east who just won an award from the RHA. And he actually was issuing these in-check devices to his patients as part of a study where they were able to personally monitor, just like you do with the peak flow, personally monitor their inspiratory flow and able to easily detect when their lung function was decreasing before they had a full exacerbation. It was Dr. Brad Drummond, who is a physician who is doing this. And this is something, if you're dealing with COPD patients, like I said, this is not an expensive device. And it could be a great tool for them to use. And that way they can monitor if they're using enough breath, too much breath, or doing everything properly, that their lung function is decreasing, in which case, time to see the physician about changing delivery systems. Next. Okay. Device technique. It is so critical. The failure is just huge with it. When I was practicing pharmacy, every time I had a pulmonary patient, every time was evaluating them using it. And I'm going to go to teach back shortly. But it's critical to ensure delivery and how it's being done properly. Like showing here, some are held vertical, some are level, don't cover the flow vents, tip sideways. In fact, if any of you ever watched the TV show House years ago, it's the actual recording that's used sometimes at pulmonary meetings, where the patient with the meter dose inhaler, when he asked her how to use it, she's spraying her neck from the outside, and he dropped a set. I had a pulmonologist who was referred a patient from a general practice. The patient wasn't improving on the Advair. And you sat down with the chart, she's sitting across from him, and she held out the device properly, clicked it around properly, and from that 2 foot distance, she inhaled. She never brought it up to her lips at all. And it's just the doctors at the practice never evaluated this simple step, which is why the patient wasn't improving. So as I mentioned earlier, the critical first step, exhaling deeply away from a dry powder unit, because you want to make sure you've got the maximum capacity in the lungs for doing it. It's the most common failure actually for all the inhalers, that you're not exhaling deeply enough. Then you'd be bringing it to the lips and making sure you're holding it properly. It's got the vents, you do not want to cover the vents up. And then having that forceful deep inhalation and trying to hold the breath for up to 10 seconds. You breathe away slowly from the device because you don't want to breathe into it because the moisture could result with the powder inside getting a bit clogged. Okay, so you want to make sure that's done. And that is one of the things that clogs it up and also messes things up. Then you're going to wipe it off with a dry tissue and you close it. Monitoring how many doses are left so you don't run out, then you're suddenly without having your medication there. Then rinse and spit afterwards so you're less likely to get a thrush infection or any other inflammation in your throat. Next. So since the drug delivery is delivered by inhaling and it's drawn up, it creates resistance designed to break up the medication, because the reason to have that strong inhalation, you don't want a clump of medication, you want it really micronized inhaling into your lungs. And as I mentioned before, the internal design is different, and the speed of inhalation for optimal will be different from device to device, where it's important to review what that is with the manufacturer's insert, hopefully that's there, or possibly a QR code on the box. And the effort required will increase as the internal resistance increases. So the higher resistance, the lower the resulting flow, and the less likely the medication might not get into the lungs. Next. So the meter device, the meter dose inhalers, the reason you're shaking it, because it's a suspension inside. So you want to get that into a suspension. When you remove the cap, the first thing you do, which this girl yesterday didn't do, is checking the nozzle to make sure it's clean. And if it hasn't been used in about 5 to 7 days, you're probably familiar that you're going to prime it the first time about a half a dozen times to getting a nice mist coming out. But if it hasn't been used for about a week or so, you want to reprime it about 4 times to make sure you are getting the mist. Like with the dry powder inhaler, exhaling deeply away from the unit, and that's where a lot of failure occurs. And then, interestingly, you never see it in the package inserts or any of the videos. They always have the people looking forward or looking down. If any of you took physics, there's fluid dynamics. If you take a look at the plumbing in your house, you do not see fittings that are 90 degrees. You will see curved pipe because you have a smooth flow of water through there. Same thing with your airway. So you want to look slightly upward, and you're holding the device vertically. You put it between your teeth and you close your lips around it. Okay, you don't want to spray at the teeth. Then one of my comparisons is making a bubble bath, but you don't spray and inhale at the same time. You start a slow, steady rate of inhalation. And after you start it, then you're pushing down into that slow, steady rate where it's going into the flow. By comparison, for making a bubble bath, some people put the soap in first and then turn on the water. Most people, from what I've spoken to, turn on the water first, and then they're pouring the soap into the flow of water, which is why you start inhaling first, and then you're going to start spraying into that moving airflow through the curved airway to get the most into your lungs. I had a patient with an asthma attack, and I gave her the inhaler because I saw she had refills before taking the time to fill it. I said, let me show. Oh, I've done this for 8 years. And she just did it rapidly, inhaled quickly and everything else. And I shook my head, no. Then I showed her, she waited a couple minutes, she repeated the technique, and she goes, in 8 years, I have never had that kind of response. Poor training, obviously, do you blame the patient? No. It's making sure the execution is done well. So when you've completed it and holding the breath for up to 10 seconds, you exhale slowly through pursed lips. The reason for that, the reason you've got a muffler on your car before your fuel injection is you needed back pressure to keep the fuel in the cell when it's being compressed. So by the pursed lips, you're actually having a back pressure that's keeping the drug from being exhaled out to keep bonded within the lungs themselves. And if a second dose is required, the reason you wait a full minute and then shake the device is it takes a little time to refill that little piece inside the inhaler, so you're getting a full dose of that spray on the second time. And the valve chamber will refill. Then just like with dry powder, you're going to rinse your mouth with water, swish and spit out. And again, checking to see how close you're going to need to get a refill. Next. So most of the MDIs, they're under equal pressure. And when you inhale too fast, you're impacting the drug on the back of the throat. You're not getting into the lungs, which is why you need that slow rate. And there are some breath activated inhalers like the autohaler that you want to have. It's mechanical actuation, but you're holding it, and it's the strength of your breath that they guide you with. You just need the amount that's going to trigger the inhaler to reach the lungs. If it's below this, it will not release. And if it's too fast, again, you're going to be inhaling at the back of the throat. Okay, moving on to the next one. Okay. Now, the soft mist inhalers are really neat. They're great for people who, one, they don't like that burst coming into their mouth. Although, of course, if they don't like that, they could use a chamber between it so you're just breathing in and out. We'll cover shortly. The thing that I've had an issue with the respiratory, and they're spring activated, it's not like a pressurized chamber, is all of them are 2 puffs per dose. All of them except the Combivent. The Combivent meter dose inhaler, the dose is 2 puffs. The Respimat is 1 puff for the full dose. And yet there's no marking on the delivery unit stating 1 puff for the dose. And I've spoken to them repeatedly, multiple years in a row at the conferences. This should be something clarified. And they have not done anything about it. And one cannot assume that a prescriber or anyone in the office might be aware of this. So that's one thing that really aggravates me is the fact how difficult it would be to put a sticker on it, 1 puff for the entire dose. Moving forward. Okay. So teachback is 33 learning approaches. Visual demonstration that they're showing you where they're doing it. Verbal is why are you doing each step? Why are you shaking it? Why are you exhaling? Why is a slow breath? Your head position, all that. Also written because not everybody learns the same way. Okay, so you want to have that piece of paper. And physical is not enough. They need the verbal. So going through these steps. Okay, moving on. So any questions?
All right, thank you very much, Mark. And we are a couple minutes over time. So if anybody can't stay for the Q&A session, we are recording this, and we'll make sure to circulate that recording to everybody who's here. We did have not a question, but we did have a comment from Andrea that when she had a patient who had Advair, she would tell them to hold it like a cheeseburger and suck like a milkshake. What do you think about that analogy? I know you like the images, so
Yeah, is actually when I was teaching the asthma with the Soccer Federation, I brought straws for everybody sitting in the audience having a plastic straw of their own. And during the entire presentation, they could only breathe through the straw to give them a relationship to what it's like to have asthma difficulty. So, yeah, I mean, like the hamburger, that's fine. Just something they could relate to in every day. And needless to say, it's more common when you're dealing with a female patient to talk about a bubble bath, because I don't think there's many guys that, unless you're an infant, get a bubble bath. So I think that'd be really good.
well, thank you, Mark. And I don't see any other questions in the chat. Thank you all for sticking around, and thank you, Mark, for your presentation. So, well, like I said, we're recording this, so we'll make sure to send it out afterward. If anyone is able to follow the link and take the evaluation, that will help us to come up with topics for the rest of the Lunch and Learn series. You can also scan this QR code to learn more information about the Chicago Asthma Consortium, or you can go to chicagoasthma.org. Um, thank you very much, everybody. And thank you again, Mark. This was a wonderful presentation.
My pleasure. It's focusing on this PIFT test for the past 7 years because of the lack of execution by the healthcare providers.
Yeah, and well, I'll talk to you about that on the side, but
Yeah.
yeah, interesting topic. All right, thanks everybody.
Thank you.
Have a great day.